Welcome back to part 3 of our Masterclass series. Today's explainer is an absolute high-stakes compliance deep dive. We're talking about protecting your practice from the very real, very heavy legal and financial risks of a 2025 telehealth audit. Look, if you're a medical coder, a biller, a compliance auditor, or a practice manager, you are literally on the front lines of revenue cycle management. And right now, the rules of engagement are changing dramatically. Let's get right into it.
So let's face a terrifying prospect right out of the gate. Are your telehealth charts truly audit-proof for 2025? Because if they aren't, you could be staring down the barrel of severe Medicare clawbacks and penalties. The COVID-19 public health emergency flexibilities that we've all kind of grown used to relying on, they're expiring. Specifically, you need to circle March 31st, 2025 on your calendars. After that date, the grace period for geographic location restrictions completely vanishes. Auditors are sharpening their pencils, and trust me, they are specifically hunting for non-compliant claims. You simply can't afford to rely on your 2023 or 2024 coding habits as we move deeper into this year.
But don't panic, because to mitigate these financial risks, there are 5 mandatory elements that every single telehealth chart note must contain in 2025. These are going to serve as your ultimate defense mechanism. We're pulling these directly from our 2025 telemedicine coding source document, and you really want to think of these 5 elements as the structural foundation of a house. If even one of these is missing, an auditor can easily knock the whole claim down, resulting in a total loss of reimbursement for that encounter. $0. Nobody wants that.
Here's our quick roadmap for today. We'll start with the 2025 telehealth audit risks, then break down those 5 essential documentation pillars, look at how to avoid the auditor's checklist trap, and finally, summarize and preview our next explainer.
Section 1. 2025 Telehealth Audit Risks.
All right, moving right along to Section 2, the 5 essential documentation pillars. Let's see what actually makes up this foundation.
These are the 5 absolute non-negotiable steps you must take on every single encounter to ensure strict payer compliance. 1. The patient-informed consent. 2. The patient's location. 3. The provider's location. 4. The type of equipment used. And 5. The total time spent. Let's inspect each of these pillars in a bit more detail, starting with number 1. Okay, so the absolutely crucial point for Rule 1 is patient-informed consent. Look, nearly every payer you'll be billing in 2025 requires it, and you must document it on every single encounter, not just the initial visit. Our source text is incredibly clear on this. You've got to get consent from the patient before performing your services over telehealth. If a patient is seen for 5 separate telehealth visits over the course of a year, an auditor needs to see consent documented in the record 5 separate times. Every encounter, every time. That literally needs to become your clinic's new mantra.
And this brings us to Rules 2 and 3. Location, location, location. Auditors are demanding explicit geo-compliance for both the patient's originating site and the provider's distant site. For the patient, you have to note exactly where they are at the time of the visit. Are they at home? Are they at a facility? Remember, after April 1st, many payers require non-behavioral patients to actually be at a healthcare facility. But our source does note an important exception. For mental health, substance abuse, or monthly ESRD assessments, the patient's home remains a perfectly permissible originating site. Now, on the flip side, the provider's distant site legitimacy is just as vital. Through calendar year 2025, practitioners can continue to use their currently enrolled practice location instead of their home address when providing Medicare telehealth from home. But here's the kicker. Regardless of where the provider actually sits, whether that's the office, their living room, or a temporary location, an auditor must be able to find that specific location written clearly in the patient's record. No assumptions allowed.
All right, Rule 4. This is honestly where a lot of practices stumble. You must clearly document your technology breakdown, specifying the exact platform brand name and whether it's a synchronous real-time encounter. You can't just scribble telehealth visit and call it a day anymore. You have to specify if the communication was synchronous, meaning real-time direct communication like a live video consultation, or asynchronous, meaning store and forward transmission of data. Beyond that, you actually have to indicate the technology's brand name. Was it Doximity, Microsoft Teams, an EHR portal? And finally, you've got to state the modality. Was it audio-video, remote patient monitoring, or just audio only? Specificity is exactly what keeps your revenue safe here. Okay, moving on to Rule 5, which requires explicitly documenting the total time spent, complete with start and stop timestamps. This is absolutely vital to justify time-based code selection and defend against those dreaded clawbacks we talked about. Whenever you're billing evaluation and management codes based on time, the stakes are incredibly high.
Our source strongly advises that you always document the total time spent on the telehealth encounter. But if you want to really bulletproof your chart, include the exact start and stop timestamps. Think about it. If you claim you spent 30 minutes with a patient, having a note that explicitly states start time 10 a.m., stop time 10:30 a.m., total time 30 minutes, leaves absolutely zero room for auditor interpretation. It is locked in.
Section 3. The Auditor's Checklist Trap. Let's pivot from theory to a practical case scenario here and look at how easy it is to fall right into an auditor's trap. You could have a medically complex visit with perfectly documented, straightforward or complex medical decision-making, but if you fail on the administrative metadata, you fail the audit, the whole thing. A super common audit failure is simply forgetting to redocument consent on an established patient. So use this master checklist to ensure every single box is checked before you submit. I highly recommend integrating these 5 questions directly into your electronic health record templates. 1. Is consent redocumented for today's visit? 2. Is the patient's exact physical location explicitly stated? 3. Is the provider's location explicitly stated? 4. Is the technology brand, synchronous status, and modality named? And 5. Are the timestamps and total time logged? If your providers can check all 5 of these boxes on every single visit, you're effectively closing the trap before the auditor can even set it.
Section 4. Summary and next steps.
So, to rapidly recap your armor for 2025, consent, patient location, provider location, technology modality, and total time. Burn those into your memory. Next time in Part 4, we'll be covering the brand new 9800 series CPT codes for synchronous audio-video visits, specifically codes 9800 through 9803, which are dedicated to the evaluation and management of new patients. We'll dive deep into how to select these codes based on either medical decision-making or total time. It's going to be a fantastic breakdown. For now, please like, subscribe, and share this explainer with your coding colleagues so they don't get caught off guard. And I'll leave you with this question to ask your team tomorrow morning. If an auditor pulled your last 5 telehealth charts today, how much of your revenue would actually survive the review? Decode Healthcare with Harshal.